Thank you. Well, hello. I'm Bob Dempsey, and on behalf of the Department of Neurological Surgery, I want to give what is our update on where we are with COVID-19, both in the nation, the country, the world, and the department. As many of you know, this is a very difficult week. This is a very sobering time regarding COVID. And it's difficult to tell whether this is still the first surge or this is the famous second surge, but I do think it is the second surge. And it was totally predicted as things change, schools restart, weather changes, people move indoors, respiratory-borne viruses become more common. That is why we have respiratory virus seasons. It's not because it's cold, it's because people clump together. When they actually study people in the Arctic that are marooned in the Arctic on an island north of Sweden for the entire winter, nobody gets sick. And it's not because they got cold or caught a chill or the things that you learned from your aunt. But when the first boat would arrive in the spring as the ice broke up, usually carrying some virus, everybody would get it. And so it has a lot to do with isolation, it has a lot to do with clumping together. And that's what happens when the weather gets cold. There are some viruses that don't do well to temperature. This one appears to be pretty much completely immune to changes in latitude, longitude, temperature, season. So what's happening? Well, this second surge has brought the world up above 40 million cases. And that's really impressive. That puts it on a par with some of the major pandemics we talked about months ago in history. To have 40 million cases in a year is not quite to 1918 levels, but it really dwarfs many of the infections that we knew of as kids, including those ones that supposedly gave herd immunity. We'll talk a little bit about that. There have been over 1 million deaths worldwide, probably 1,100,000. The U.S. has a disproportionate share of the disease. 8.2 million cases, 221,000 deaths. For a modern country with fabulous health care, that's a disgrace. Wisconsin, which was spared from the first wave, in April and May, we were hunkered down. We did wonderful things. We took credit for it, but frankly, mainly because our people didn't travel from the hot spots like New York, China, Milan, we didn't really get a very big dose. We have recently. We had 4,591 cases yesterday, which is 10 times what we would get in a day in April or May. Our hospital, when I last checked, had 44 patients, a good number in ICU, but not yet overwhelming. Madison is over 100 patients who are hospitalized. And we are really seeing the impact because what we're seeing is that percentages of tests are high. Where we used to test 100 people and we get one positive, we're getting 20 positives. We're beginning to see friends, colleagues, coworkers, staff, and patients turning positive. And that means that we're canceling surgeries. It would be rare, one every couple of weeks, where the random sample of society that was coming in for elective surgery and was tested would be positive. Now we're learning that they are infected. And it's very important to understand, while in September, we correctly noted that the sick people were 18 to 20-year-olds, college freshmen, out on their first lark where they went off to school to our state campuses and one private campus in state. They tested, tremendously positive. They didn't get that sick. Some of them did. One of my daughter's students died in North Carolina. So it's more rare, but they do get sick and they can get devastating brain kidney, heart problems, as was the case with these. Most of these people who are sick do have strain on those organs. Whether they have long-lasting consequences is not known. The problem was they spread it to the middle ages, their parents, and those people have been spreading it throughout the state. Part of this is a big change from urban to rural disease, which is overwhelming the small hospitals upstate. And it does not appear, much as we might want to make a political statement, that these people are infected at large group gatherings. It appears to be more small family social events, more 2 or 3 families getting together, people mingling as if this wasn't a pandemic. And that's what happens when people get fatigued. We've had lots of this going on. We've seen, as a result, 2 different, very contrasting things happen. More restrictions are placed. Number one, the governor has tightened restrictions on restaurants, group gatherings. Schools have tightened down, and we'll talk a little bit about that because UW's tightening down was very effective. We've seen things that, have been challenged in court, sometimes successfully. You don't have a right to tell people to not harm themselves or each other. Some courts believe that. But this is a country where it's illegal to drive your car at 200 miles an hour down the highway because you'll probably kill somebody. It may be more rational if you were a rational judge to say you don't have a right to infect somebody. And we've seen remarkably dangerous behavior modeled by public figures. Now, there's been a huge improvement in our campus, and that's important to know. And they're very reluctant to loosen anything up. But by really mandating masks, separation, virtual teaching as much as possible, their rates plummeted from 20 to 1, which is better than the random population in Wisconsin. So it went from being the real local hotspot, the campus, to being a place where there's fairly sensible restrictions in place. Now, again, universities can do that. They can do things like forfeit your tuition if you don't pay attention, and it's been successful. Now, what are we doing? Well, the UW surge plan is both the school we talked about, which directly affects our student learners. Fortunately, not the med students as yet, but a lot of the undergraduates are still formally and informally restricted from expansion of labs. But here within our building, we are able to keep the labs open. I feared for more restrictions. We have not had them, but we have more bureaucracy, more paperwork, more things to go through, which is actually a good thing because it holds us accountable for making this a safe workspace. Indeed, while we're seeing a troublesome number of staff providers in the hospital becoming positive, the vast majority were infected at home and now cannot come to work. We had some providers infected by visitors, and therefore we have shut all visitors off. I obviously am advocating that the visitors are necessary, especially for their disabled family member, especially for brain and cognitive problems. But the answer to that, in my opinion, is we test the visitors. And if we can test the football team daily, I think we should be able to test the hospital visitors. I'm working on that. Now, what are we doing? Well, we're trying to be prepared for a surge. If we have 40 unexpected patients in the hospital, we can get by, but we're very worried about an increase. Our medical ICUs, and we're much more sensible this time than that first surge about how we're going to change the hospital. We realize that if we just cut everything down and wait for COVID, all of those people that we take care of will be disserviced by loss of their hypertension control, their diabetic control, their brain tumor. I'm still taking care of people that were disadvantaged by the lack of medical care during the earlier part of this year, and they came to us with bleeds in their brain from untreated hypertension or tumors that are out of control. So we're trying very strictly to not stop anything that's essential. And essential is defined more broadly as these things that keep us from getting sick. We are cutting back slightly on electives, and we may have to do more. We have, as a team, been decreasing on average 1 case per day, just because that would fill hospital beds. We are trying rapidly to open up the new unit on D44, which would take 12 new beds into play with nursing. Unfortunately, they have not had a very sensible approach to training the nurses, so it's going to take longer than I'd like, but some of the beds will be coming online in the first week of November. That'll help. By decreasing elective ORs, we actually decrease hospital beds. It's very hard to decrease medical beds because they wouldn't be in the hospital without, you don't usually come in the hospital on a medical service electively. And we know that, although the bar of what gets you hospitalized, it changes if the hospital's safe or not. Nevertheless, we are committed to keep the vast majority of our surgeries going. That's an economic reason for that. It is the engine that brought us out of the tremendous debt that we were in by May. And it allows us to keep people paid, keep the doors open. But more importantly, most of the surgeries that we're doing need to be done or someone's going to die. And, getting the tumor out in a timely fashion remains essential and important. Getting the stroke treated, essential and important. And we made that argument forcefully, and it works. Nevertheless, we are throughout the department sharing, I'll give up a patient this week. And we don't give them up, we postpone them. And I make darn sure they aren't postponed twice. So far, so good, but the world changes. So we will, though, clearly be told not to do non-essential things. The hospital is really saying, at least for the time being, some things like marketing or things like that, they're just going to wait. So we count our blessings. Look at the science and what that's doing. Right now, the science of vaccines is in a brave new world. I could have predicted a year ago that it'll take 4 years to get a vaccine. I really do think we'll have a vaccine by the end of the year. Whether it works or not is going to be contentious and difficult to tell. I suspect by the time it's really up and available, we'll be into March or April. I'm kind of focusing on March and April because that's when the 1918-1919 pandemic, after 14 months, died out. And so I'm watching our timeline, which is now at 10 months. 10 to 11. So I'm really hoping that we can do the same. I'm not scheduling meetings, etc., in person prior to that. And I'm advising national leaders, etc., forget about their spring meeting, try to hold it in the fall. It gives us sort of an idea where we are. We're living with COVID, but we are, by really looking at multiple ways to make a vaccine, multiple different parts of the virus to attack, and throwing them all out there to see which one works. We're spending a huge amount of money, which we couldn't do before, but this is the investment that the country is making to try to find a vaccine. And indeed, it might come from another country, but there will be one. I'm pretty confident of that. Drug studies are ongoing. They will decrease death, no question. Medical studies are doing that. And that's why we are having, yes, more deaths, but not the same rate for all these cases we're getting compared to April and March. Indeed, the virus may be changing, but so is our treatment. So use your time well. We're looking at a winter where people should be productive. This is my opportunity to brag on my daughter, who, using her time well while isolated, published all of her research and won today her university, which is Appalachian State, the University of North Carolina campus, a Young Researcher Award for the campus. So she takes after her mother, as you can tell. But that's really what you all should be doing. We all should be doing. I'm happy to say that the first grant from Dr. Wesley that has been judged this week was scored extremely positively. These are people who are using their time productively, and she will probably be well funded by the NIH for that. Use the electronics, the ways that we're doing this meeting. Frankly, I get more people to this meeting than I would have if we held it in person, and I realize that. That's not that I don't miss being in person. We need that to network. But on Saturday, this department taught in Turkey, in Madison, and in the Sudan, switching from program to program and teaching to very, very interested audiences who got a lot out of it. So we're going on. So don't stop living. Respond to the hatred which is going on, and the fear, and the envy, and the disease with strength, compassion, and wisdom. That's what medical people do. That's what we do best. That's how we get through this together. Look out for each other, especially those people you hold dear, which should be everybody. And my final message is vote. This is what we do in America. This is what separates us from dictatorships. Vote. This is your chance. There are opportunities to do that in person, starting yesterday or today, by mail, or in person on election day. I believe it'll be relatively safe as long as you mask, keep your distance. And I don't believe it'll be as crowded as it usually is because people are voting early. So please act as a U.S. citizen, act as a physician, staff, nurse, provider, or support person. Be proud of what you're doing. I'm very proud of you. Thank you very much.